Hey guys, and welcome to the Performance Hub podcast, and thanks for tuning in. So before we get started, we want to let you guys know about an amazing offer we have going at the moment. Using the coupon code COMMUNITY, we have 1 month free access to the Performance Hub. So this is our online member site where we have tons of content from in-depth exercise tutorials, videos on different strength and conditioning methods, program templates, articles on nutrition, stress management, and just a ton more content. So head over to www.pipeperformance.uk to sign up and get started on that today. As well as that, below this video, we've linked all our social media channels, as well as all of our guest socials. So go and like and comment and share, as it really helps us to be able to produce more content for you guys, like the interview that we have today. Okay, so that's enough of that. Let's dive into today's interview and see what it's all about. Okay guys, we've got a real pleasure today and a real honor to be joined by Dr. Stuart McGill. We've spoken in this interview about lots of aspects of back pain in sporting populations, the biopsychosocial model of pain, and how Stuart interprets that and uses that working with his patients. We've looked at several different kind of interventions for pain, from stretching to foam rolling to lifting, and how and when to use those kind of modalities. We've dug into lots of different things. I've tried to really cater the interview towards giving people takeaways that they can start putting into their own training or their own kind of recovery from back pain. So if you've got an interest in helping people with back pain, or if you've experienced it yourself, I really think you're going to get a lot out of today's interview. And we had the pleasure of being shown around the BackFit Pro clinic, which is unlike any clinic that I've seen before. So we're going to start off the show with that tour around the clinic, and then we're going to jump into the interview.
I'm in BackFit Pro. I don't know if you want a tour with your people or not. There's all our various models that I use to teach patients. If we go around to here, cables, we got all our fight gear for the combative athletes. That's where we watch game films to go over what the demands are and perhaps movement opportunities for different athletes.
Brilliant.
Kettlebells, bamboo bars. We've got things for skiers and those kinds of things. That's a very special hamstring trainer. It's a standing one for the strength athletes and sprinters with back pain. That's a belt squat machine. We got various Cybexes. And I know people get into me sometimes. They say, oh, well, you don't like sit-ups. Well, if sit-ups become intolerable, say for an MMA athlete, and we take them out, then of course there's still a hip flexion component. So we'll use Roman chairs, and got a 200-pound heavy bag for the boys who want to bang, and a little gallery of some mementos from some athletes over the years. But anyway, that gives you a rough...
Yeah, no, I mean, that's, what there probably aren't too many kind of therapists' offices that look like this. Not that I've been to anyway, and I've been to see a fair few kind of physios and chiropractors and different.
Well, I don't really. This is in my house, by the way.
Oh, really? Wow. So we're here today with Professor Stewart McGill. I think, and I'm sure I'm not alone, that he's probably one of, or if not the leading expert in kind of assessment and management of back pain and injury in all populations. He's a professor emeritus at University of Waterloo, and there's countless papers kind of published around back pain, and worked with countless professional athletes, and has written lots of different books, and is just a very, very well-versed person when it comes to back pain and that experience and how to manage it. So we're really honored to have you here with us today, Stuart. And I don't know if you want to just give people a little bit of background, how you kind of got to where you are today.
Well, good morning, Henry, first of all.
Thank you.
And I suppose it's afternoon or evening for you in the UK. Where are you in the UK?
We're down south. We're in Portsmouth, so right on the south coast, and it's about 2 o'clock at the moment.
Yeah, I know Portsmouth fairly well, actually.
Oh, brilliant.
Yeah. Well, I was a professor for 32 years. We ran two different laboratories at the university. One was what we call an in vivo laboratory, where we created a technology that would measure the patterns that an athlete or a person used to accomplish a specific movement, function, or goal, or whatever it was. Might have been a sporting event. We would measure their muscle activation patterns, three-dimensional motion, spine postures, and all these sorts of things to help us allocate stresses and forces throughout the body, but obviously focusing on the spine. And from there, we were one of three laboratories in the world that actually measured spine stability as one. So, for example, as a combative practitioner yourself, you know that if you want to throw an arm strike, let's assume that the person was training something like bench press to create that type of athleticism. We have a uniarticular muscle like pec major, the bench press muscle, and people think that's what creates a hard strike. But that muscle distal to the ball and socket joint creates the desired arm flexion, but proximal, it creates a bend of the rib cage to the, so if all I use is that muscle, that's not a very effective strike. But when we build proximal stability, and now we fire the cannon from a battleship rather than a canoe, 100% of that muscle activity goes to creating the effect. And then we would measure the role of fascia and how athletes in particular turn all of the muscles into agonists to create tremendous athletic effects. So that all came from the in vivo laboratory and rather unique findings. We had an in vitro laboratory where we took real spines and we created injuries to them. So we would get a one-to-one understanding of the pathway through to tissue failure. We had a radiology suite where we would then image the injuries and do microdissection afterwards and whatnot. So it was a much better training actually than radiologists get. We were able to see things and knew what to look for on images that the medical radiology experts never received. And the third part of it all was about 25 years ago, I started an experimental clinic. And we can talk about that as well. But that was the basis for our unique findings and probably perspectives over the years. And I retired from the university 3 years ago. We sit now in BackFit Pro headquarters, which is a clinic, gym, training center, pain place, whatever. I don't know really what it is, but it's actually in my home, well north of the university, well north of Toronto. So people fly in from around the world, actually. And
looks like an incredible place to get some assessment and treatment.
Yeah.
So so some of what you said there, in terms of the access to the assessment and the depth you could go to when looking at how people are moving from a sporting perspective, but maybe just from a lay population perspective as well, and what might be, causing people's back pain, must have been such a, amazing opportunity, and probably not an opportunity that, the majority of practitioners have around the world, I'd imagine. And maybe that's going to kind of answer my question that I'll have for you initially. But in the UK, we have this kind of diagnosis of what they've termed non-specific lower back pain. And I don't know if that's a diagnosis they have in Canada or other places in the world, but certainly it's something we have here. And the treatment often for this is kind of psychotherapy, cognitive behavioral therapy, which is, you know, the management of emotions and thoughts and feelings, and how we can kind of, you know, modify our behavior based off of that, or not modify our behavior based off of that. But it's a difficult sell, I think, for a lot of people to be told that their back pain is not necessarily being caused by a physical mechanism, but perhaps is being caused by a psychosocial mechanism. I know I've heard you speak about this, you know, at times in the past, but I'd be interested to get your thoughts now about where you kind of, how you look at this kind of diagnosis of non-specific lower back pain and our approach to it in the UK.
Right. It's a major concern from several perspectives. First of all, non-specific back pain to me means that there has been no diagnosis at all. There hasn't been a thorough assessment. Have you ever heard of a patient coming in with non-specific head pain or non-specific leg pain? It wouldn't be tolerated. No. Why are people tolerating this with their back pain? And you're correct. It leaves a lot of people in despair, absolutely clueless as to what is causing their pain. It lets the clinicians off the hook. They cannot give a competent assessment, so they give some garbage assessment, and it lets them off the hook. They shouldn't be, in my view, allowed to even see a patient if their best effort arrives at a diagnosis that doesn't help people. Now, having said that, if the cause truly is from a psychosocial milieu, a proper assessment will show that. However, if it's caused by the way the person bends over to pick their child up out of the crib, then that's a different issue, and that has to be addressed. So I'm sure you've seen studies published on non-specific back pain. Every single one of them shows nothing works or everything works, but it violates statistical scientific design. You can only do a randomized controlled trial on a homogeneous condition, whereas back pain is highly non-homogeneous. There are people who have different mechanical intolerances. There are people who have neural situations with, you know, radiating pain, et cetera, et cetera, et cetera. So it retards scientific progress. It's terrible for the patients, and it allows incompetent medical practice to exist. How's that for an opinion?
You're not sitting on the fence. I like that. I mean, maybe it might be, the NHS is such a great service and does such a great job for a lot of people in the UK. But unfortunately, I guess this could be potentially one of the drawbacks in a kind of government-funded healthcare system, in terms of having the resources to just really study and look into kind of the causes of people's back pain.
I think you're being way too generous. The NHS is fabulous for someone who has cancer. I think they're being very ill-advised when they do not train clinicians to perform a thorough assessment that reveals the cause of back pain or the pathway to pain. As you may or may not know, our assessments are 3 hours long.
Wow.
You see, clinicians are paid to perform procedures. The procedure has a code, so they have to bill for a code that fits their particular scope of practice. Whether or not it's appropriate for the person is the problem with the whole NHS system. So people will go for repeat visits of a treatment that may be appropriate by dumb luck, or maybe not, in terms of their back pain condition. However, with a front-end assessment, it will reveal the cause of pain, then it will direct an intervention that first and foremost addresses the cause, then guides the building of the base foundation that person needs to function pain-free, and then it will guide progressions to whatever the end goal is. I can prove this. We've been studying it for years. You're well aware of my book, Back Mechanic.
Yeah.
I wrote that because of groups like the NHS. Instead of telling people they have nonspecific back pain, we guide people through 9 diagnostic tests. They self-administer those tests and record the findings, and then it shows them that why, when they sit at the computer for 20 minutes, their legs fall asleep, they get sciatic pain and back pain, and when they go for a walk, their pain goes away, or the next person sitting down takes their pain away and going for a walk causes it. There's a reason for all of this. It's not non-specific, so when they understand the reason, they know with precision what to do and what not to do to wind down the pain sensitivity.
So I guess, I know you guys have practitioners in the UK for BackFit Pro, and I'm sure there are, countless practitioners who've read your books and are kind of singing from the same song sheet. So I guess if you're getting that kind of that feedback from the people you're seeing, that there's maybe a psychosocial reason and you're potentially not on board with that diagnosis, it's finding another practitioner or doing some research, maybe reading your book, Back Mechanic, and trying to kind of get to the root, or if it is a physical root.
Well, we follow up with every single patient. That's another one of our mandates. So let's take a typical therapist. A patient comes for treatment. Maybe they do well. Hopefully that's the case. If they don't do well, they don't go back. What does the clinician think? Oh, that person got better. They didn't come back. Where if they performed follow-up, it's a very humbling exercise. They will find, no, they made that person worse. We're one of the few groups, we started this at the university, we followed up with every single patient we ever saw. We know with exact precision our score. We know what the person came in with. We know what we gave them as a diagnosis. We know what we advised them to do. We know whether or not they complied. We know how they were after 6 months and after 2 years. So I know exactly our clinical score. Not too many other people can do that. But getting back to that biopsychosocial, can I start with a little bit of a preposition to that? And if you want a bit of a short essay on that, I can give you one. The pathway to pain is a huge variable, and it's different in every single person. So the assessment, if it's thorough, will show if they have a very, very specific pain trigger. If they sit and they sit upright and they say, no, I don't have any back pain, pull up on the chair. Does that cause back pain? No. All right. So it's not caused by compression. Now, extend. Oh yeah, there's my familiar back pain. You just proved it was posturally driven by spine extension. Then allow the neural tract to drift away from the head, which is in a caudal direction. And they might say, oh yeah, no, my pain is worse. Okay, now flex your neck. Oh yes, my pain is better. So we're already within 60 seconds determining the posture that's driving the pain. And now we also know there is a neural component, whether we'll determine whether it's a friction as the nerves move, or it's purely a nerve tension type of mechanism. And then layering the test upon test, we will get right down to the precise level of the spine, whether it's from a disc bulge, whether it's from an inflammatory soup around a fresh disc bulge, whether it's from a growing pair of facet joints or ligamentum flavum. We'll get right to the mechanism, also on a tissue base, which some people say is not possible. And my answer to them is, I think they need further training. But this idea of the biopsychosocial approach, it's rather humorous to me that this is apparently something new to clinicians. When we started the clinic 25 years ago, our initial appointments were 2 hours long. I was the chair of the Department of Kinesiology at the university, which had 4 groups: physiology, biomechanics, neuroscience, and a psychosocial department. That was what I had to represent. It was as broad a biopsychosocial department as you could think. Some of my medical colleagues said 2 hours for a back pain meeting. What are you going to do? Well, after a year, I changed it to 3 hours. Start by having the patient tell us their story. And we ask very probing questions. For example, do you get a sharp pain when you roll over in bed? If they say yes, that is almost always a sign of joint instability. They've lost a little bit of disc height, and at one level now, that one level is experiencing micro movements that's triggering pain. All right, we now know from our score sheet that stabilization exercise for that particular answer to the question will show they do very well. The next person comes in with stenosis, and they don't get that kind of pain, but they get pain when they walk. And if I pull this rod through the central canal here, there's no friction. But as soon as I bend that ever so slightly, the rod gets hung up. And all I have to do is change the posture ever so slightly, and we free the nerve. So you see, in that case, it has nothing to do with stability. In fact, there's too much stability there. It will be just coaching very subtle postural changes. Well, maybe they have a ligament deficient knee, and they hold their knee in a particular posture for their knee, which travels to the pelvis, which travels to their spine, making that postural adjustment rather difficult. So I'm afraid, particularly in the UK, this discussion of the biopsychosocial approach has formed a trichotomy, as if those three things are different. But what you think determines your posture, your demeanor. Clinical depression, if you look at a clinical psychology textbook, clinical depression and the posture that is adopted by a patient is knees together, flexion forward, hands folded here in a position of defeat, waiting for the next person to drop a load onto their back and cause pain. Versus getting the person to sit up, yell, I own the world, get cracking. They know what causes their back pain. They start to address it. Now, was that a cognitive behavioral therapy that I just performed? Or was it biomechanics? Or was it neurology? In fact, it was all three. So there's an example of, there's no trichotomy here. They're all linked. And when you look at the work of Professor Bill Maris, for example, who's led this area, he did psychological profiling of different workers, and then he stressed them. He would have a boss come in and yell at them and berate them and whatnot. It turns out personality determines how much of that mental stress and fear goes into their body. So the introvert crushes their own body. They increase compressive load down their spine another 25%. The extroverts, it's water off a duck's back. They don't manifest that stress physically in their body. So, you know, I could go on and on about this. As I said, I think we've been very cognizant of the biopsychosocial model for my entire career. And but there's people on the internet who says, oh, McGill, you're a biomechanist, you don't consider psychology. And yet when people come here and practice with us, they'll say, well, that was the most biopsychosocial assessment and intervention that we've ever seen. We were unaware, we didn't know. So yeah, I think talk to some of our clinicians, and I think they will enlighten you and the public on this whole issue.
So it's interesting. That's not, I hadn't thought about it in that respect before, but it's interesting the way you're looking at that model and applying it. So it seems that the mechanism of the pain is always going to be some physical, issue, if you like, and then that is being caused by perhaps a postural issue, or the way someone's carrying themselves or moving, and then out from that is being caused by that psychosocial aspect. Maybe it's a mental health issue or a you know, a social problem.
Or maybe they hate their job, or their kids are enabling their disability. You know, oh, Gran, can I give you another piece of chocolate cake here because you're in terrible pain? Just sit in the chair and we'll feed that. But, you know, Henry, when a thorough assessment most of the time will lead, so you were correct. I'm just going to summarize that just a little bit. Think that genetics loads the gun. So we all have different leg length to body length ratios. We have joint architectures that suit certain types of sports and loads. You're a jiu-jitsu practitioner. By definition, you will have to have shallow hip sockets. If you have deep hip sockets, you will not be able to roll on the floor, play in guard, and that kind of thing. You would have to do it entirely through your spine. So genetics loads the gun. Then it's mechanical exposure that pulls the trigger. Then it's the psychosocial milieu that modulates how the brain perceives, the emotionals interact with all of this. So very much it's people just don't say, oh, I'm stressed, I've got terrible back pain, so when I bend forward to flush the toilet, I felt a knife go into my back. That wasn't a psychological issue. That was 100% a violation of their existing condition, which in that case was almost always a open fissure in the annulus of one of their discs. And hydraulically, the person bent forward, squeezed their spine, and they would get a tiny little bubble coming through the delaminated collagen, and it would touch a nerve. Now, in 3 or 4 days, that slowly resolves, the inflammatory soup clears out, etc. But instead of blaming that on a psychosocial cause, if we showed them, you know, next time I'm going to teach you how to play cricket. Go down and play outfield in the cricket. There's the posture. Now, pull your hips through. Oh, yes. Now, flush the toilet. Perfect. You just eliminated the cause. By the way, that's weightlifting 101. Sniff a little air, lean forward through the hips, and pull your hips through. But here's the thing. Weightlifting expertise and coaching is not in Western Europe. That expertise is Poland, Bulgaria, Ukraine. And when I travel to those countries and teach and work with their teams, I never have to mention latissimus dorsi, quadratus lumborum. They know it, it's in their culture. But if I go to certain places in the US or in England, they don't know this. It's a different culture. It's so interesting. And so they get sold things like, oh, transverse abdominis is an important stabilizer of the spine. Yet every single person who knows how to lift heavy knows that if you suck in your abdominal wall, you just inhibited your ability for the hips to drive and lift. Do the opposite. You actually poke your fingers and push your fingers out, stiffen it and harden it. Now the brain perceives that stability and safety and gives full neural drive to the hips. But as you know, when you have a little bit of pain, the brain shuts down. Now, if you have knee pain, you will limp. But if you have back pain, the neurological response is to shut down strength and density of neural drive to the entire body. It's horribly disabling and so psychologically intimidating as well. So, you know, again, we get back to this. I'm just absolutely mystified on some therapists now discovering the biopsychosocial model. I question, what training did they get? But here's the thing about physical therapy schools. I see new graduates now who know nothing about mechanical assessment of back pain. They have been trained 100% that you start with cognitive behavioral therapy. So we're going to have another wave of unidimensional practice. And I'm afraid the therapies, they've eaten their young. They're becoming so self-obsolete. What they knew 5 years ago, they forgot. What 5 years ago they knew 10 years ago, they forgot. And I'm not condemning physical therapists as individuals. There are some fabulous individuals and there are some incompetent individuals, just like there are professors. However, the profession seems to anoint a guru. They follow that guru and forget everything that went on 5 years ago instead of accumulating knowledge and wisdom. But anyway, there's enough about all of that. But
seems like a misinterpretation of that model, and the way that you've kind of explained it there, I think, is incredibly encouraging for someone experiencing back pain, because being told that the back pain's in your head and we're going to have to go through this kind of, like, the mechanism for pain is a psychological mechanism that's causing it. Being told that is can be quite disheartening, and having to think about going through, cognitive behavioral therapy where we're not actually going to deal with the pain, we're just going to learn to manage it because it's in your head. I mean, very frustrating situation. Whereas if someone's listening today and they've been in that situation, hearing a better interpretation or a different interpretation of that model is much more encouraging, because it's saying, okay, well, look, there's still there's still a physical mechanism going on there that can be addressed. We just need to understand that the psychosocial aspect is impacting and potentially, like, kind of igniting that physical mechanism which is causing the pain. So I think that's really an encouraging kind of way of looking at it.
If in the assessment you ask the person who's suffering, can you name some activities or positions that make your pain worse? And can you also tell me some positions or activities that take your pain down a notch, or maybe even take your pain away? Almost every single patient will be able to name those activities. Now you build on the things and the capacity that they have to be pain-free, and you create movement hacks to accomplish the tasks, avoiding the things that they just mentioned to you causes their pain. That is so psychologically empowering. That is cognitive behavioral 101, a genuine conversation empowering them on their own to create strategies moving around their pain triggers and wind it down. Was that mechanical? Absolutely it was. Was it psychological? Yes. Is it a form of high-level CBT? Absolutely it is.
Yeah.
There's no trichotomy here. Only unskilled clinicians. So I'm not letting them off the hook.
No, and I think you're right. I think you're totally right. And it's as a clinician, one should want to further their kind of practice and not accept a kind of, like you say, a get out of jail free diagnosis, if you like. It seems like there should always be a root cause. And like you said, if there's a root cause to the majority of other, or all other physical ailments, why would there not be a root cause to back pain? One of the other things that I'd kind of wanted to speak to you about, and this is again somewhere where I've seen potentially people being on different ends of the spectrum and experiencing back pain. We've mentioned a little bit about lifting today and weightlifting and learning about certain movements and how that can impact on people's back pain. But I've heard you speak about this kind of this range, if you like, or this spectrum from your kind of professional powerlifter being on one end and then your yogi master being on the other end, and how we have this kind of range from super flexible and that being needed for that person's profession to super stiff and that being needed for that person's profession. And potentially when we see people with back pain, they might be somewhere on that spectrum. Is this something that you'd keep in mind and have people trying to kind of move around this spectrum to kind of start dealing with people's pain? I guess I'm talking about kind of using modalities to kind of help people. Would we, is stretching going to help everyone? Is lifting and core stability going to help everyone? Or do people kind of fit on this spectrum?
Well, you've asked so many questions in different layers there. I'm trying to find a start, but you're causing me to create a little bit of an essay now. But how about this? As I said earlier, genetics loads the gun. There are some people who, by being touched by the hand of God, they're highly flexible. Mm. They are not the ones who are going to lift on a powerlifting platform. They're too flexible. A spine is a flexible rod. In order for it to bear heavy load, it's got to be stiffened. So not only is there an innate stiffness there, I mean, look at powerlifters. They walk around in Birkenstock shoes because they cannot tie their laces. Tying the lace would demonstrate flexibility that would be such a disadvantage for a very strong athlete who has to bear a lot of load. But it prevents them from doing yoga. It prevents them from competing on a jiu-jitsu mat, for example. So most people are somewhere in the continuum from highly mobile and flexible to highly stiff. They're somewhere in the middle. So now comes the challenge of tuning their body to have just the right amount of mobility and just the right amount of stiffness, because by definition, the body uses stiffness to control movement. I'm able to sit here because of stiffness in my core. If I didn't, I would just collapse because that flexible spine, it can only support about 20 pounds or 8 kilo of compressive load. And then it buckles. So it needs muscle all the time, forming guy wires like on a ship's sailing mast, but it all has to be tuned. So take a golfer, for example. A golfer is an elastic athlete. What we saw on the PGA Tour, for example, about 12 years ago, some prominent golfers became enamored with Olympic lifts. Almost every single one of them became disabled. That was the wrong tool to create an elastic athlete for golf. Golf, as you know, is to disassociate the rib cage and the pelvis. Now, if you put heavy load down through that position, the tissues and the tolerance and the repetitions to failure greatly diminishes. Mm. If you lock the spine in a neutral position, it can take tremendous load. Mm. But if you start moving it and then combine high load, you've created a situation where the cumulative micro trauma to the tissues, it accumulates faster than the rate of repair. So they got the training tool with the wrong posture. So those golfers now, many of them have recovered, and I know some of these cases quite intimately, by restoring, taking away the high load and working with tools now to better tune that elasticity on that continuum of stiffness to mobility. And yet a golfer, a great one, they need the elasticity, and then when they come through the ball impact, there's actually a little stiffening pulse. The external rotators of the hip drive a pulse and then create a recoil through a whiplash action. And so you can have a very modest physicality hitting a golf ball 300 yards. Whereas you won't find a rugby prop who can hit a golf ball that far. They are too stiff and far too strong. They're untuned for that particular type. So again, it was a lack of expertise and understanding in how to tune that particular athleticism. Now, everything in tuning is a trade-off. I'll just talk physiology for a second because people understand that a little bit better. Take a person who has a high VO2 max. They're an endurance athlete. Not one of them is explosive because the explosive metabolism is competing all the time with the endurance metabolism. So, you know, in MMA, for example, the very explosive fighters, they have to win in the first round. So the battle plan is survive the first round, have sufficient endurance, and then get them in the second and third. But that person who lasts to get them in third round has less explosiveness. Okay, so it is with the deal with the devil. You're tuning the body, gaining on one, you will lose on another. So now you've got to know those trade-offs. And if you want to be a yoga master, it would be unwise for you to train strength. And we see this when we look at back pain mechanisms in yoga masters. The collagen of the discs become loose because of the adaptations from continual pushing the end range motion with not much load. But then when they do load, the loose collagen then tends to delaminate. And we see when they bend forward, a bulge in the front of their spine. And when they bend back, we see a buckling mechanism because of the loose collagen. And yet the opposite occurs in the strength athlete, like say you have someone training at the gym or a CrossFitter or a power lifter. They get disc bulges posteriorly when they bend forward, precisely the opposite of the yogi. So, you know, I can cut this down to so many layers. Here's an example too that came to mind. Take an NBA basketball player who can dunk a basketball, taking off from the heel of one foot at the top of the key on the basketball court. They fly through the air. Let me ask you a question now. Do you think they have loose hamstrings or tighter than normal hamstrings?
Would be probably quite tight to.
Yes, they are. Yeah, absolutely. So now most therapists would say, oh, you've got back pain, you've got tight hamstrings, let's stretch your hamstrings. They would ruin that ability to jump. So these are the things and the reasons why people come here, to recognize what their goal is, the precise mechanism of their pain, and a very specific approach, recognizing the trade-offs all through science and the assessment to achieve their goal. So it's a little bit of an essay, but you did ask me 4 questions there, I think. Oh, the modalities, there's another one.
Well,
so,
just with a couple of questions on what you've said there.
Yes, please.
Just while you were talking, we were looking at, you know, potentially your genetics dictating potentially how best or where you may end up physically, the things that you might go and do, sports, interests, things like that. If we take someone who is very flexible, who's been experiencing back pain, potentially has got that more kind of yogi type genetics than the kind of powerlifter type genetics. Previously, I would have always said that some sort of lifting for this person's probably going to be helpful, because we might want to kind of stiffen them up a little bit. Potentially, they're a little bit too flexible for their strength, if you like. They're going to points where their body can't support, and they're ending up experiencing pain. But maybe if we're looking at what you've just discussed, that kind of model, maybe that wouldn't be the best approach for that person, because we're asking their body to do things that potentially it's not set up to do.
Well, it will be fine for some and not others. It depends on their competency of the lift. So if they have a lot of flexibility, and that is regionally dependent, I hope they have a lot of hip flexibility and not much spine flexibility. There would be a perfect Olympic lifter, for example. But nonetheless, power lifter, I would like a bit more stiffness in both of those areas. Sure. But nonetheless, just get me locked on target there now. You were talking about, should a flexible person then go to the lifting platform? I would suggest not. You have to do a lot of homework first. I would suggest you build a core of iron first. And I use that as an analogy. It's almost a shocking statement to some people, but I've just done a little bit of cognitive behavioral or psychology with you. I want to shock you just a little bit because I need a behavior change from the trainer. Build a core of iron first. And the best exercises for most people are what's known as the big 3. And that will prepare their spine with the neurology and the residual stiffness to start increasing their load-bearing capacity. Now start coaching the lifting movements, lifting a broomstick. Again, I'm giving you Eastern European strength training and lifting training 101. This is not what I see in the UK. Lift a broomstick, get the competency, and then keep learning how to pull the hips through if the lift is a deadlift, for example. Yeah. Deadlifting was unknown in the UK 20 years ago.
So that's interesting. Yeah, I find that's very interesting. So you're saying, because previously I would have, you know, maybe 5 or so years ago, I definitely subscribed to the kind of the thought of you don't really need dedicated core work, and your big lifts are going to do it. You know, handling, you know, hundreds of kilos of weight on your back, your core's getting lit up pretty well. And you probably don't need your planks and side planks, bird dogs and curl ups and things like this. But certainly, I think in the last 3 or 4 years, I've kind of changed that, and that's kind of where you're going with that. It's laying those almost like a GPP phase, if you like, laying the foundation of core stability before letting someone kind of start lifting.
Yes, if someone has pain, a GPP phase is always non-negotiable. I suggest you go to the front page, the home page of our backfitpro.com website. Across the bottom, you will see world record holder after world record holder in different lifting sports. They've all been patients, every single one of them. Even though they set world records, they then became injured. We had to rebuild the core, tune their bodies, GPP, and every single one of them, with the exception of one now that I can think who's on there. And by the way, that's about 2% of the world-class lifters that we've seen. I've seen world-class female record setters, many males, and I don't buy into that supposition that the sport creates a core of iron, not at all. Another group is the professional bodybuilders. They have wonderful looking cores, but they're suffering with back pain. A lot of them neglect it. They want a thinner waist, whereas the strongest, most stable cores have much bigger guy wires, a bigger base. And here's a thought for you. Have you ever had a patient come in or a client with real noticeable and measurable joint instability, micro movements that are triggering their back pain, and they have a large belly, so large that it comes down and maybe forms a pendulum touching their thighs? You know, the big bulky belly that I'm talking about. Yeah. Have you ever in your career had one of those who had an unstable spine? Because I can't think of one ever. That bulk is just the girth and the mass ensuring stability. They have other problems and other mechanisms and pathways to pain, but I can't think of one where it's joint instability. So there you go. There's just layers upon layers, and what we do, all of us, I mean collectively, you and me, is pattern recognition. And when you know the patterns, you will know why jiu-jitsu people have clusters of mechanisms in the sport. You know why Olympic lifters have a cluster. You know why a CrossFit athlete is yet another different variety. And, you know, it gets you on track very quickly. So it's non-specific. It's just incompetence. It's highly specific. So there's a lot of layers to getting past this idea of something being non-specific. You know, think of gymnasts. What if I said, I'm going to give you a 14-year-old female with low-grade back pain, but she gets sharp triggers of back pain every time she lifts her chest? You know that you're probably looking at a spondylitic fracture, a stress fracture. So, you know, that was the pattern. It fit, and that becomes a much quicker assessment because you knew the pattern. There's no non-specificity at all. Mm-hmm. You know, you can tell my visceral emotions starting to rise up now with this allowing clinicians to be incompetent and no one is holding them accountable.
And for anyone who gets into the field of working with people and trying to help people with pain or, you know, weight loss or whatever it might be, ultimately you want to help people. So I'm sure it doesn't fit right for a lot of people to kind of give people that diagnosis. Using the example that you gave, just to go into that a little bit more, just in a MMA or jiu-jitsu specific context, because I know that, you know, a lot of the people that listen to this will be from those backgrounds. Using the example you gave of the golfer who's getting into positions during their swing where you wouldn't really want to be applying load to those positions because of that lack of stiffness in the torso. In jiu-jitsu and MMA, we are going to see lots of very odd positions going on where the spine is not in a great position to be kind of taking a lot of load. And so if we start thinking about, you know, that and that presentation being quite, you know, widespread amongst jiu-jitsu people, everyone seems to have some sort of bad back. Do you think we maybe should be rethinking the way that we're working with these populations in the weight room when it comes to strength training?
Well, I can prove it. I've measured it and I've kept score. So it goes beyond thinking. I think I have the numbers to justify. So if I can riff on that idea just a little bit, because as you may or may not know, we've restored some careers of some top name UFC athletes, Abu Dhabi submission medalists, etc. So we and personally, as you know, I love jiu-jitsu more from the cerebral. It's a chess match, as you know, and your object is to give your opponent checkmate. However, there's three options out of this, and all of them are nasty. So that's jiu-jitsu. So am I a good practitioner myself? Absolutely not. I've got the most non-jiu-jitsu body you could imagine. I've got very deep hip sockets. In fact, I am hip replaced, if that gives you any idea from being young and training deep squats. Pardon?
Do you train in jiu-jitsu?
No, I just roll with some of the best jiu-jitsu masters in the world to experience their world.
Yeah, brilliant. What a great experience.
So I'm lucky. I get to play with the greatest athletes and feel what their athleticism is.
Yeah.
There is in fact, we're coming out with it very soon. I'm just having a little roll with Matt Brown from the UFC.
Yeah. Wow.
And just to prove to people, you may have heard, oh, posture doesn't matter for back pain. Really, you get in the cage with Matt Brown and 1 millimeter change in your posture is the breaking point between you breaking and going into the hospital, or you can get out of that submission. 1 millimeter. So don't tell me posture doesn't matter. I'm going to send you to jiu-jitsu class and you'll change your opinion very, very quickly.
Yeah.
So going back to this idea, here's a typical scenario. And again, I've worked with the first family of jiu-jitsu, and you know who I'm talking about. Top practitioners. Typically speaking, they will do 200 or 300 sit-ups every day. They will push the palms of their hands flat to the floor as they stretch, etc. They do not lift heavy weights. So they're quite careful in the weight room. The problem is if you start adding that much mobility with strength, you will probably shorten the career of available high tolerance to the spine, nonetheless. So let's say we have someone who's established a good career in the UFC and they're now 24 or 25 years of age. They come to me, I can't train jiu-jitsu, my back is so troublesome. Can you help me? And I'll say, yes. Tell me about your training. Tell me, again, it's a 3-hour consult. And I say, all right, just as an example, we're going to take out all the flexion movement for a while. They say, but for me to roll jiu-jitsu, I have to play in guard. I have to go to full flexion. I said, yes, but you're so disabled, you can't train now, your career's finished. And they agree. So I say we're going to replace the flexion movement with flexion moment. Now that's the difference. So instead of doing sit-ups, we're going to do stir the pot on the gym ball. And by the way, if you think you're ready for a championship bout in the UFC, which is 5 minutes on, 1 minute off, that's rolling around, times 5. I want 25 minutes duty cycle stirring the pot. So people are a little bit misimpressioned with what level we can go to here. But nonetheless, we don't trigger their back pain. Now, we've done this with military groups. You know, there's various militaries around the world, and the UK right now is looking at replacing speed sit-ups, which is their annual fitness test. If you want to be a Royal Marine, you have to pass the speed sit-up test. What we do, because this training the speed sit-up test is causing back pain, disabling to some of those war fighters. That's too bad, because some of them have wonderful potential. What we're going to do instead are front planks, stir the pot, front plank, roll to a side plank, touch the elbows, locking up the core, but creating tremendous abdominal, anterior chain, torsional resistance training. Now they're training in no pain. Now they go back and challenge the speed sit-up test. They've had the highest score they've ever had with 0 back pain. And so is the story with the jiu-jitsu fighters. They then are back in the UFC, top level competition. They're back at Abu Dhabi, and we've restored their career. Now, they are limited in the amount of flexion movement. They have a capacity. They save that capacity for the mat, but they don't train it. And that is the world of difference. So we've created a core of iron, and they express their athleticism when they need to. And if they violate that capacity, they become disabled once again. And usually they take 2 or 3 cycles of that, because they have a Y chromosome. They're a fighter, they're a boy, they're going to challenge that again. And they say, oh, damn, McGill was right. I violated biology. It's time for me now to readapt my biology to become tolerable once again. By the way, they are so psychologically empowered and souped up. When does the psychosocial begin and stop? When does the mechanical begin and stop? But anyway, there's a little bit of an essay on jiu-jitsu. And here's a little bit of a fun, well, yeah, I was going to reveal a personality. I check that. I won't bother. But if you ask around in jiu-jitsu circles, I think you'll find out.
It's that's completely kind of put everything on its head in terms of training, you know, MMA and jiu-jitsu guys, and it's a very different kind of way of looking at things to the way that I've previously approached, you know, S&C for combat athletes. But maybe by chance, some of the people that I've worked with, we've taken a similar approach to what you're talking about, because they've had very traumatic back injury. So either, you know, a herniated discs, or one chap had a kind of a burst disc historically, and then after several years, 5 or 6 years, had come back to jiu-jitsu and wanted to kind of try and strengthen himself up to roll and keep training, not to compete or anything, but just to keep training and not be in so much pain. And he gets a lot of neural pain, a lot of, you know, neuropathy and things like this. But we'd avoided any spinal compression. And I know when you briefly showed me around your clinic there, you had a belt squat machine. And that's something that we'd utilized heavily, was the belt squat machine, to avoid any spinal compression. And he'd had some really, really good results with it, you know, excellent results. And we weren't really doing any barbell squatting. We weren't doing any hinging because of the load going through the spine. And we've taken more of a kind of, I guess, joint by joint approach in terms of his training, and he'd had some really good results with it. But then we looked at training the core with specific core exercises rather than with the big compounds. Is that kind of more the approach you take with someone who's having like a lot of back pain and is having to do a combat or a contact sport where that
absolutely. Every tool, every exercise, every bit of gear is simply a tool to get a person to their goal. Your job, my job, is to choose the best tool, the most efficient tool to get to the goal and create adaptation to buttress that historical injury. So, of course, we use a belt squat machine. Think of a downhill skier. I've had two Olympians who fractured their spines taking tumbles coming down the hill at 75 miles an hour. But they have to get into a aerodynamic tuck and they will round their spine and then they hit moguls at that kind of speed. Anyone who's done that knows that is tremendous load down the spine. But could a traditional strength and conditioning coach train that? They might put a bar on the person's back. You cannot put a person's bar on the back when they're recovering from a fracture in that position. It's not possible, but I can do it with a belt squat machine. Take a cycling athlete, top endurance athlete or a top sprinter. We build a core of iron with other ways, but we build legs from God with the belt squat machine. Yeah. So, you know, there's wheels within wheels within wheels. The issue is most strength and conditioning coaches have a set equipment list in their gym. But here, as you see, we think out of the box. We have all kinds of little gizmos. Some of I've welded up myself to create the challenges, to create the adaptations, knowing what the sport demands, but knowing the history of the athlete and what their deficit in. Here's a key question. I had an athlete here yesterday who was ready for the Olympic trials, although they've been delayed now with this whole virus situation. But I said to the athlete, if I was able to grant you one wish, one athletic wish, now we'll address your back pain, but in terms of your performance, one athletic wish, what would that be to put you on the podium? And you know, they hesitated and they had to think about that. And I subtly mentioned to them that they need a new coach. If that coach has not determined the priority of what they need to get on the podium and are training with specific targets to make that, they've got the wrong coach. Every athlete needs to know with precision, what do I need to get on the podium? And they better get training the difference or the deficit. Otherwise, they'll never make the podium. So, you know, wasn't that an interesting exercise that came out of the assessment? Was that a psychological category of probing? Was it mechanical? It was everything. And for the first time, someone had a genuine conversation with them to point out to them, here is a little bit of an opinion. I've assessed you now. Here's what I think. Oh, and they say, yes. If I only had that, that's the weakest part of my game. All right, now we're going to address that while we're organizing your rehab to adapt your spine to resilience once again. But anyway, these are all little, I guess this is why people come here. They're somehow, anyway, again, this, it amazes me that people find these new, oh, it's the biopsychosocial approach. Well, what have you been thinking for 30 years?
Yeah. So looking at like the kind of combat and contact athletes, obviously you've seen a fair few of them by the sounds of it. I've got a good experience there. What are the sort of, what would you say are the kind of common themes that you see amongst these guys who are engaging in MMA or jiu-jitsu where like, what would you say are the common themes in terms of the impact on the spine, kind of longer term from training like this?
Well, the common pattern are disc bulges. That is the root of their disability. So it comes now, what is the cause of a disc bulge? Well, it depends on the person. So if we take a thin willow branch and bend it back and forth, there's no stress, but that willow branch won't take much load. That is a person with a slender spine. God gave them the advantage for lots of mobility, but gave them the disadvantage of ultimate load bearing. The next athlete, or let's go back to a thicker branch now. You bend that branch once, one cycle, it shatters and breaks, because the bending stress is a function of diameter, radial distance from what's called the neutral axis. So now you take an athlete with a very thick spine, bending is not what they were made to do. They were made to bear big loads. So right away, just assessing that person's anatomy, assessing with a hip scour exam, the type of hip socket they have, right away we'll know whether they're qualified to squat, what their squat depth should be, how wide their hips should be, all of these kinds of things. And then we look at, well, what's your training history here? Now tell me about, what is your game in the cage? Are you a jiu-jitsu emphasis? Are you a stand-up striker? Are you a takedown wrestler who, like a shoot type of strategy? And then we'll say, well, okay, that suits your anatomy, or it doesn't. But so you work with the skills coach to maybe create a new equipment list of skills, and work with that athlete to adapt to meet those. It's a team. To put someone in the UFC, you need a fabulous strategy coach. You need a fabulous conditioning coach. And I could name for you, if you told me, here's an athlete, they fight in 8 weeks, it wouldn't be me who would tune their physiology and just peak it so they're just primed for that night. But I know who to send them to. If they have back pain, I'll look after that. If they, here's something that you will really gravitate to and talk about, a biopsychosocial approach. When you get to know the top fighters, you really form an intimate relationship with these people. And they will tell you, the honest ones, perhaps the greatest challenge they have between winning and losing is handling fear. So leave the dressing room and walk through a stadium now and climb into the cage. Do you know what that feels like? I don't. I've never done it. But I've been with them and can imagine this. Fear to me is stiffening. I don't like heights. So if I have to go on my roof to do a shingle repair or something like that, my knees lock up and I have to sit on the roof for 10 minutes to gather my psychological disposition so I can even move on the roof. If you get fear as a fighter and you get just a little bit stiff and you start to push the punch rather than letting it fly, you're going to the hospital really quick. It's not like losing a tennis match. So to figure out the music, the staying loose, walking into the cage, that is an art form. To get into the cage and stay loose and not allow that fear to stiffen their body. It's psychological. It's so psychological and mechanical. So there is yet again another layer of what we might do and what we might mimic. So when we're training, we will induce fear. I will induce fear in the assessment, because if I don't pick up that strong reaction in that athlete, I just missed the reason why they have back pain and the reason why they're losing. So, the cognitive behavioral therapists, are they picking all of this up in their assessment?
because the ones that I see, obviously there are people helped with that pure approach, just cognitive behavioral therapy. But I don't see those. I see the ones where cognitive behavioral therapy has gone horribly wrong. Now the person has been led to believe that their psychology is causing their back pain. They can live with their back pain, but they cannot live with the fact that they're crazy. Now they come to McGill, suicidal. Look, doc, I can't stand being crazy. You can't help me with my back pain. I'm giving myself lead poisoning in 2 weeks. You've got 2 weeks, sir. That's the state that they come here. Absolutely tragic. So this is, but anyway, there's a component of fear and chaos that the average person who's never been in the cage would even know about.
No, indeed. I mean, we've spoken a lot about, we've kind of touched on a lot about different kind of modalities of treatment, and we've looked at that biopsychosocial model and how that people are using CBT and things like this, and obviously people are aware of surgeries, and we've spoken a little bit about lifting, but often people are kind of using strategies like foam rolling or the kind of guns, and they're using stretching and things. What do you think? There's a place for modalities like this in terms of managing, or
Yes, there is. Everyone is a tool. But if you go to a massage therapist, you are going to get massage and stretching. Now, that may help, or if you have an unstable joint, they just made it even more unstable. They took away the natural stiffening protection that your brain is organized to keep that pain-free.
So would you say, because often this is something I hear a lot, and it's something I've felt myself, and certain clients that I've worked with have gone for massage, or maybe an adjustment, or whatever treatment the physiotherapist or massage therapist has deemed appropriate for that person after their assessment, and they've gone away, and that day or the next day they've kind of felt like they were experiencing more pain. Would you say that that is okay, that's part of the process, or would you say that that's not, they've maybe not given them the right treatment in that instance?
I think the latter. Yeah, when I see the assessments that determined the modality of choice, I'm not impressed. However, I know there are people who say, oh, there's no place at all for modalities and manual therapy and whatnot. And I would say, well, that's interesting. I've never seen one of them with a gold medalist or even a bronze medalist at the Olympics. I haven't seen those people there. Who I do see there, I have a colleague here. So I have a Rolodex. And obviously, I refer out when I don't have the expertise. So if I have an Olympic sprinter here with back pain, I don't know of a medalist, sprinter, hurdler, high jumper who does not travel with a good manual therapist to tune and know precisely what to allow to stiffen, what compliance you need to tune a spring, say in a foot arch. If you want to win, that spring had better be precisely tuned. And so here, I mean, in the States, I'd probably send them to Arizona and Dan Paff. Dan Paff has more of his clients winning Olympic sprint medals than any other coach that I know of. He's such a modest guy. I think if you asked him, he wouldn't know. But if you just go through and look who's winning, there you are. Watch Usain Bolt train. If you don't think that's a team. Anyway, here I have a therapist, Larry Bell, who will tune that sprinter's elasticity throughout the chain much more precisely than I, just to unleash that gold medalist speed. So is manual therapy good for everybody? No, it absolutely is not. But if you want to win a gold medal in sprints, I don't know anyone who's done it without. So, you know, these people who have hard opinions, oh, get rid of manual therapy, get rid of all of these various modalities. I don't know about that. However, they're horribly misused on the other hand.
Sure. Maybe that, you know, a lot of people kind of reference the lack of, you know, good quality research proving the mechanisms of the reason or why they work.
Right.
Maybe it's still a bit unknown as to why foam rolling or massage really actually kind of works, or how.
No, I'll disagree with you 100%.
Did you say you disagree?
That's because the studies are done on non-specific back pain people.
Right.
And what the studies do show is when you subcategorize people into homogeneous groups and you make the group very tight by definition and through assessment, now you will find out truly on that very small subcategory of pain mechanism what modality tends to work and what tends not to work. That's point number one. Point number two is the variance of the human spectrum. So let's take, well, just a common study on caffeine. Is caffeine an ergogenic aid? Does caffeine help you to perform better? You may have an opinion on that, but what the data shows is, say you're going to play a game of ice hockey, you will have a 3% ergogenic enhancement of your play, however you define that enhancement. 3%. Most people would dismiss that and say that is not important. On average, there's their conclusion. So most people get their knowledge from Facebook and reading abstracts of scientific papers. They are not masters of the craft. The master of the craft will go back and read the studies that they reference and what they reference, and learn the craft. It takes many years. Now let's go back to that study that said there was a 3% ergogenic effect of caffeine. Go study the variance. There was 200 people, non-specific people, in that study. 40% of them were super responders. They had a 25% enhancement due to the caffeine. 20% were the super non-responders. Caffeine made them sick. It unsettled their neurology just a little bit. And there are genetic reasons, etc., for all of this. Anyway, on average, there was no effect. But the master looks at the variance of response. Now you start subcategorizing. What was the feature of the super responders, and what was the feature of the ones that caffeine made sick? Now, if you knew that, you would become a master. And so it is with every modality as well. Some hurt. We talked about stretching and massage. Strategic massage. So I've already revealed that I've had hip replacement. I would, I'm fairly prominent at medical meetings, and I would be at a meeting and I'd be hobbled and leaning on the podium speaking somewhere, and some guru was going to speak on hips next. They come up to me at lunch and say, "Can I treat your hip for you?" Anyway, and then they do, and they crippled me for 2 weeks after. They weren't a master of the craft. They spoke well at a podium. And then the next person, anyway, long story short, there was one clinician who lived in St. Louis. His name is Dr. Clayton Skaggs. I would go and see Clayton every 3 months. I'd make the effort. I had pain-free movement for about 2 months every time after I saw Clayton, and he balanced things up. He did it with his hands. He was a master with his hands, knowing what to stimulate. So he might create stability through nociception. He would create pain and get a neurological response and then unleash something else. Just such a master of the craft. There's my experience. Some clinicians turned me into a cripple, but the masters unleashed pain-free ability. There's such variance in clinical expertise in everybody, in professors, police officers, and manual therapists. So, to throw everybody under the bus is It shows me that person is just not at the level of clinical mastery yet. So most of these things that you mention, for someone, somewhere, someplace, it will help. And of course, some of them are absolute charlatan techniques. I get that. But for a lot of the therapies, there's a time and a place, as there is for surgery, as there is for everything else. But the assessment, if we want to finish up on this point, assessment is always king. A thorough assessment tells you about the person, about the mechanism, about the impediments in their life that have always caused failure to get them pain-free in the past, be they the social milieu, be it the stress accumulation of their movement habits, whatever the mechanism is, the assessment will reveal. And then the skill of the clinician will organize a set of tools in a progression to pull that person out. And the final piece I want to say is some people can't be helped. No one has 100% success rate.
Man, amazing stuff, and I think you're right. And it's like you say, going back to that assessment and knowing your patient, and then using the right tool for the right job. But I really appreciate you coming on and talking to us, Stuart. We covered kind of a lot of different subjects there, and I think for the listeners from combat sports backgrounds, but also from like a kind of general population background, there's a lot of kind of good takeaway points there that people can start looking to kind of action to help, with their back pain or help avoid back pain, and kind of some performance tips in there. So there's a lot of good stuff in there that people can kind of take away and utilize. Do you want to kind of mention where people can get hold of you, your BackFit Pro and your clinic, or if they want support and help with their problems?
Right. Well, our website is backfitpro.com. I have my books and some videos there. We're just about to make some of my courses online, so they'll be out in another month or 6 weeks or so. But there are some papers on there that will help people, some different back supports to assist the flexion intolerant backs when they sit, and that kind of thing. But there's 2 portals, one for clinicians and one for back pained people to enter the website, and they might find that helpful. But other than that, I don't really have the time to get onto social media, but Sarah here at BackFit Pro, she does our social media, and apparently she does a good job at it. At least that's what I'm told. But other than that, that's about all I can really say. I do say before I will see a person, they must read Back Mechanic, my self-help book, to guide them through a self-assessment. And truth be known, and I followed this up, 95% of people who read the book and follow the details don't ever need to see me. Wow. And I know that number through follow-up. Now, there are 5% that they truly have perhaps multiple mechanisms of pain, and they're obviously a bit more challenging.
Yeah, that's a great stat, coming back from the book, and I have read it and reread it, and I really get a lot out of it myself. But yeah, thanks for coming on today, Stuart, and I hope the lockdown that we're all experiencing isn't having too much of a negative impact on you guys. You're enjoying some time at home with your family.
I am. All right, Henry, good luck to you, sir. Thank you very much for all of the work that you do in assisting to get the message out.
No worries. Thank you. Thanks for coming on. I really appreciate that. It's great to get the chance to talk to you in person.
Okay, good day to you.
Thank you. Cheers, Stuart. Okay, guys. Wow, that was a real honor for me to talk to Stewart McGill. He's someone that I've followed for a long time, and I've got one of his books. and I've watched a lot of interviews with him and just digested a lot of his content, and it's really helped me manage my own back pain as well as helped with management of back pain within my client group. So that was really special for me to be able to talk to him one-on-one like that, and I hope you guys got something from that and took some action points that you could start putting into your own training or your work with your clients to help people or yourself with back pain. We've got some great interviews coming up, looking at topics like sleep and training for dads and hydration and lots of different things. So keep your eyes out for the coming podcasts. If you're interested in taking your training to the next level, then go to our website, highperformance.uk, and sign up to the Performance Hub, our member site, where there's tons of information on health, well-being, training, all aspects of training. So, go and sign up there and you get a free month with the coupon code community. So literally it's just free information. Go and digest as much of that as possible. Try, if you can, to like, share and comment on this podcast or any of our content, because it really helps us to produce more content like this. And guys, we've got some great interviews coming up, so stay tuned and we'll see you next time.